Continuing on with chapter 22, so we'll go through the patient assessment portion. So scene safety is first and foremost, just like any other call. You want to take a little bit more time to look at your patient's response to the environment. Is it or could it become potentially dangerous for you or your partner? If there is that chance, should you call law enforcement for backup so that you have some people? Should you stage until emergency personnel or law enforcement has arrived on the scene? And oftentimes your dispatcher will help make that decision for you. When you consider the circumstances, does your patient's behavior seem typical for that? And then are there legal issues that are involved? Is it a crime scene, consent, refusal? And then take appropriate standard precautions and make sure that you have those additional resources there. For your mechanism of injury, nature of illness, you're going to determine that like you would anything else, but you might want to take special note of any medications or substances that could contribute to the complaint that may make it seem more of a relevant medical condition rather than a psychiatric complaint. For your primary assessment, form your general impression. Again, general impression is from the doorway or a distance away. We're not doing that after we've already talked to the patient. Make sure that you introduce yourself. Make sure that you ask permission. Make sure that a person has an altered mental status still has autonomy over themselves. Perform a rapid physical exam. Look for trauma, especially head trauma. Observe the patient closely. Continue to check the AVPU scale. So the easiest way to do that is just keep talking to them. As long as they're talking back to you, you should be relatively good. Most of our medical or trauma situations will include a behavioral component. So make sure that you treat the whole patient. You have the medical complaint or traumatic complaint as well as the behavioral portion of that. So a lot of times our treatment is also going to consist of emotional support as well. For primary assessment, establishing life threats, so airway, breathing, circulation, every patient is going to respond a little bit different. It may be that they're hyperventilating. It may be that their heart rate is racing. So just make sure that you compare what you're getting to the situation and determine if it's appropriate or not. And then for transport decision, unless the patient's unstable from a medical problem or trauma, take the time that it needs to gain the patient's trust and to get them to go with you. Oftentimes, if you have law enforcement on scene, let them be the show of force. You be the good guy, they're the bad guy, and just say, hey, you know, why don't we just take a ride? You and me, we'll just take a ride. And you don't have to be that authoritative force that says, no, you're going to go to the hospital. You don't have a choice. Let the police do that. You be the good guy. Because otherwise, once you get in the back of that ambulance, unless you take an officer with you, now all of a sudden it's you and your patient in a small metal box. And if they want to get violent, there's not a whole lot you can do at that point. For your history taking, investigate that chief complaint. You're going to obtain a sample history just like everything else, but you want to consider 3 major areas that could be possible contributors to what the patient is experiencing. Has the patient's central nervous system, is it functioning properly? Are there any drugs or alcohol that could be a factor, especially hallucinogens? And then, have there been any significant life changes, illnesses that could be causing this reaction more as a mental factor than a physical factor? For your sample history, you may not be able to get them to talk. They may be unwilling to tell you anything. But you still want to ask about previous episodes, any treatments or hospitalizations, medications that they take. In geriatric patients, make sure that you consider Alzheimer's disease or dementia as possible causes of abnormal behavior. Unfortunately, both of those at some point do tend to make the patients either more combative or just unwilling to react with their environment. Determine the patient's baseline status and how this deviates from that. But just know that your assessment really has two main focuses. So recognizing major life threats and then trying to reduce the stress of the situation if possible. So here's some more questions here in 22.2. You want to use reflective listening to gain insight into the patient's thinking. If you have to, you can repeat what the patient has said back to them in question form to make sure that you truly understand. And using that type of listening tool can help show them that you are listening, that you're paying attention, and it can help them expand on those thoughts. For your secondary assessment, your physical exam, with any unconscious patient, we're going to begin with the physical exam after we do that ABC so that we can rule out trauma, especially head trauma. You want to complete a thorough physical exam, obtain vital signs. With a patient that is conscious, if they're very upset, you may not end up getting a set of vitals on them because we don't want to upset them further. You can make every effort to assess blood pressure, pulse, respiration, skin, and pupils, but if they are not handling the situation well, you may not get a blood pressure. The rest of that, you can probably pick up okay without letting them know what you're doing. You want to consider whether prior events such as any sort of physical agitation, use of stimulants, alcohol withdrawal, or somebody that's been tased may have contributing factors to what the patient is experiencing in that moment. A conscious patient may choose not to respond to your questions. However, you can tell a lot about a patient's emotional state just from their facial expressions, how they hold their body posture and conduct themselves, their pulse rate, and then their respiration. Tears, sweating, blushing kind of give you an idea of what's going on. You want to look in the patient's eyes. Like a blank gaze or rapidly moving eyes could mean that there's some sort of central nervous dysfunction, either from medical complaints, trauma, or it could be altering substances. Transport decision. When available, have somebody ride with you, especially if you were the only one in the back of that rig, because one-on-one with a patient that is violent, unpredictable, and in theory is not thinking rationally, it's not going to be a fair fight, no matter how strong, tough you are, etc. So just take somebody with you to ensure your safety and the safety of the patient. Make sure you know where you're transporting the patient to. We do have a behavioral health facility here in Sioux Falls, but if need be, the ERs do have rooms specifically set up for those with behavioral issues, but you need to let them know well in advance because they have to prep those rooms. They often have a protocol to follow and what can be in the room, what can't be in the room, etc. Definitely go by ground rather than by air. That being up in the air can contribute to the emotional distress that the patient is experiencing. And transport in a position of comfort. We don't have to necessarily put them in a specific position, kind of let them do what they're doing as long as it safe. As far as your reassessment, never let your guard down. Always be ready for anything the patient could potentially do and be prepared to intervene very quickly. Many patients that are having a behavioral crisis tend to act very spontaneously, very irrationally, and sometimes they don't give a whole lot of warning as to what they're going to do. If restraints are necessary, and this is generally a last-ditch effort, reassess and document the patient's respirations, pulse, motor, and sensory function in all restrained extremities every 5 minutes. So we're going to continue to reassess that. It's often that they're going to pull and fight at the restraints, so we need to make sure that they're not cutting off their circulation. For interventions, first and foremost, try and do what you can to diffuse and control the situation and then safely transport the patient to the hospital. Oftentimes when a patient is emotionally distressed, we do end up feeling empathy for those patients. And there's oftentimes very little that we can do in the short time that we're with them. But what we do for them, such as just listening, truthfully can have a huge impact on them. Be aware as your standard precautions. If you encounter a situation where you think that pharmacologic restraint is necessary, request ALS backup as soon as possible. For your communication and documentation, make sure that you give the hospital advanced warning. Again, they might need to prep those rooms. They may need time to get security staff down there to ensure that everybody is as safe as possible. Make sure that you let them know if you have restraints on the patient, which type of restraint you have. Oftentimes we only use the soft restraints, but there are several different types. And then why you put the restraints on. Make sure that you communicate to the hospital anything that you've observed at the scene that may explain why the patient is acting the way that they are, and then document thoroughly and carefully. Especially if you put restraints on, you need to justify why you did that. Physical emergencies or psychological emergencies, psychiatric emergencies, behavioral emergencies typically have a lot of potential for legality to them. So make sure that you document everything that occurred, especially go into detail with the situation around the use of restraints, because false imprisonment is a huge thing. If you take them to the hospital, it can be kidnapping. And oftentimes, once the patient is out of that acute state, they may get very, very frustrated and decide to come after you as a means of feeling more in control of their situation. So we'll go on with specific mental and behavioral issues here in the next video.